Good afternoon. My name is Karen, and I will be your conference operator today. At this time, I would like to welcome everyone to the Complementary and Alternative Medicine, What Myeloma Patients and Caregivers Need to Know conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Ms. Robin Toohey, you may begin your conference.
Thank you, Karen. Good evening, everyone. I'm Robin Toohey, Senior Director, Support Groups of the International Myeloma Foundation, and it's my pleasure to welcome you to tonight's teleconference on complementary and alternative medicine, what patients and caregivers need to know. I'd like to thank our sponsors for their support of tonight's call, Celgene Pharmaceuticals and Millennium, the Takeda Oncology Company. If you have not yet downloaded the slides for today's teleconference, please go to myeloma.org and click the top bullet under New and Noteworthy, and you'll be able to access the slides there. Tonight's teleconference is part of the IMF's Living Well with Myeloma teleconference series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. You will have the opportunity at the end of this presentation to ask questions. It's now my pleasure to turn over the call to Diane Moran, Senior Vice President, Strategic Planning of the International Myeloma Foundation, who will introduce you to tonight's speaker. Diane?
Good evening. It is my pleasure to introduce Sandra Kurtin, who is a distinguished member of the International Myeloma Foundation Nurse Leadership Board. Sandra has over 28 years of oncology nursing experience. She's a worldwide lecturer. She's an associate editor of the Journal of Advanced Practitioner in Oncology and on the editorial board of Oncology Nurse. She's published in numerous peer-reviewed journals, including the New England Journal of Medicine and the Clinical Journal of Oncology Nursing. Sandra, comes to us from the University of Arizona, where she's a nurse practitioner in hematology and oncology. And so with that, I bring you Sandra Kurtin.
Thank you, Diane, and welcome to everybody, and thank you for joining us this evening to talk about complementary and alternative medicines, frequently now used to explain that is the term CAM, therapies, and we're really going to focus primarily on what myeloma patients and caregivers need to know. So with that, we'll move on here to slide number 2. So I think the first thing to really touch on are some of these definitions because they've been evolving over the last several years. And so some of the common terminology that you may hear is integrative medicine, integrative oncology, or complementary medicine. And these terminologies are more the same than different. So a lot of that is being melded into one form of practice or some variants of that depending on where you are in the country. When we talk about complementary therapies, we're talking about things that are adjunct or supplemental to mainstream treatment. So this is not an either-or situation, but a combined modality in trying to meld the best of both worlds, if you will. The goal really is to control symptoms and enhance well-being, so that fits very nicely with the living well with myeloma theme. And some of those options include things like what we call energy therapies, things like acupuncture, massage, meditation, yoga, Reiki, biofeedback, and music therapy. Nutrition, good nutrition is always a positive thing, and this may include standard doses of dietary supplements. And then we always try to encourage integrating exercise into your day-to-day life because we know that that brings improved health. When we talk about alternative therapies, these are usually alternative to common or mainstream therapy. Some of these may be promoted as surrogates for mainstream care. Many of these have not been proven, and we're going to go through some of the most commonly used strategies as we go through this lecture. In some cases, patients may choose this as a complete alternative to mainstream care, or what some people call Western medicine, And the most common forms here are herbal and dietary supplements. So we're going to go through some of those and really review some of the literature and the data that's available to date, both in mouse models and in human beings, to look at why some of us as clinicians make the recommendations that we do. So if we move to the next slide, slide 3, the first question we want to say is how common is the use of supplements? So we're now just talking about supplements. So this is a well-written study in the Journal of Clinical Oncology looking at studies published. So it's a meta-analysis, what we call in science a meta-analysis. So somebody goes and they look through all the studies from 1999 to 2006, and there were 32 studies. And they looked at adults after a cancer diagnosis, and 64 to 81% of the survivors used reported use of any vitamin or mineral supplement, and 26 to 77 reported using multiple vitamins. About 50% of U.S. adults used dietary supplements, and 33 used multiple vitamins or multiple mineral supplements. So fairly common use of supplements. 14 to 32% of survivors initiated this after their diagnosis, and the things that were associated with use were a higher level of education, being female, and yet 68% of physicians were unaware of supplement use among their cancer patients. So what this tells me is that there's an opportunity for having a conversation between the patient, the caregiver, and your providers so that everybody is working from a common base and we're all aware of what everyone is doing so that we can avoid some of the pitfalls that we might discuss here as we go through. When we look at the next slide, slide 4, and we look at dietary supplement use in Community Hospital Comprehensive Cancer Center, this is a particular center, 227 newly diagnosed adult cancer patients, again, 2001 to 2003, and 73% were using some form of dietary supplement. Many of those people were using them during their chemotherapy, so 71% of those patients, and most of them had taken it within the last 30 days. Roughly 53% did not have a conversation with their physician at this time. And a separate study looking at 951 cancer patients, only 3.7% perceived dietary supplements as not beneficial at all. So most people believe that these would enhance the outcomes of their care. So why are the patients using them? So we know they're using them. We want to understand why are patients using complementary and alternative therapies. And this makes complete sense when you're dealing with myeloma. One of the goals is to alleviate symptoms. You want your therapy to work the best that it can and increase the chance for a cure or a favorable outcome, improve your tolerance, improve survival, quality of life, reduce stress, and enhance immune function. So we're going to talk a little bit about some of the things that are out there that make these claims, some that have been proven and others where we're really looking to have more information. So when we look for proof and whether it's safe or not safe and effective or not effective, the difference between prescription drugs is that there's a very formal regulatory mechanism through the Food and Drug Administration, so the FDA. And for supplements, they do not come under these same requirements. So when you look at this table, and this is from the USP.org website, which is what is based in the Food and Drug Administration, you see that prescription drugs must go through this rigorous process of clinical trials and then proof of putting, and they have to meet with the FDA in a formal way to say it's safe, effective, it does what we say it does, and then we're going to follow it after it goes to market. That's called post-marketing surveillance. The good manufacturing practices, or GMPs, are based in this pharmaceutical realm, and disease treatment claims are therefore allowed because there is that level of science, and it's been proven at a statistically significant level. When you look at supplements, so anything we purchase over the counter, whether it be a vitamin or an herb or whatnot, none of these same requirements exist. And they use safety recommendations or guidelines that are used for food. So food safety guidelines are what are applied to these supplements and herbal medicines. So a very different set of metrics when you look at how things are tested tested and proven, if you will. So the next slide, slide 7, USP Verified Supplements reliably contain the ingredients listed on the product label in declared strengths and amounts. So basically it says what you say is in there in the right percentages. It will break down and release ingredients in the body within a specific amount of time. So when you take it, it's released. And that they do not contain harmful levels of contaminants. And what that simply means is that what's in there is only the ingredients that you say are in there and nothing more or less than that. And they basically are following the good manufacturing practices that are used for foods. So, and I've included the website on this slide, so there's a lot more good information on that site, so that if you would wish to do that, you have the opportunity to go and learn more about specific compounds and about these criteria for safety. So if we go to the next slide, one of the other things that we always consider in our practice, and myself as a nurse practitioner have conversations every day with patients, is that anything you take or ingest has to be processed, metabolized, and excreted, meaning moves out of the body. And so the organs that are normally necessary to do that are the liver and the kidney. And we know in myeloma in particular, the kidneys are often challenged just by virtue of the disease and some of the things that come because of the proteins involved in myeloma. So in general, we look at age-related factors. We know that the average age for a patient with myeloma is in the late 60s and early 70s. And so some of the things that are common just in that age group are different changes in the body, such as the way the fat is distributed, muscle mass, and some of that affects how drugs are metabolized. We know that protein-calorie malnutrition, so if you're not having a good appetite and you're not eating well, that may interfere with drug metabolism. We also know that the liver and kidney have certain changes as we age, and they may affect the way you metabolize drugs. So the important thing here is that if you are taking a lot of things at once, the liver may have way too many things to do, and there is the chance that drugs may become toxic, and that would include supplements and herbal compounds. And you can have certain compounds we'll talk about as we go forward that can be toxic to the liver, and that may then change the way that your myeloma therapy, your active therapy, or treatment plan for myeloma is either beneficial or become too toxic. So very important to understand, and another reason why you really want to have open conversations with your providers about anything that you're taking, whether it's prescribed or over-the-counter or alternative in the sense of herbs. One of those things that become a factor, so we're on slide 9 now, is something that we call the cytochrome P450 pathway. And any of you that have ever been on a clinical trial understand this, that there are these prohibitive drugs. And we go through your list and we talk about the things you should or shouldn't take while you're on a particular study. And this is because the liver, as I mentioned, and this is this little picture in the square there, it's very vascular, and drugs have to be metabolized, filtered, detoxified, if you will, and then excreted, often through either the bowel or the kidneys. And some of the things that are commonly taken may interfere with other therapies and or may be toxic to the liver all by themselves. So I'm not going to go through this in a lot of detail. It's there for you as a resource. But again, another reason why we want to have open conversations about anything that you're taking during your treatment course or at any time. We may see changes in some of the laboratory measures that we're following, and it's important to be able to consider anything that might be affecting those as we move forward. If you go to the next slide, slide 10, so this gives you just a little glimpse of some of the common things that people take, so the CAM product and some of the interactions or adverse effects that may happen. So, for instance, vitamin E, ginkgo, garlic, ginseng, ginger, white willow bark, many of these very common things that people take can affect anticoagulation. So if you're taking Coumadin or nonsteroidal anti-inflammatories, they they may make the bleeding incidence much higher. Similarly, St. John's wort or SSRIs, which are serotonin inhibitors, these are mostly antidepressants, can affect the way the opioids work and make them more sedating. They may actually make birth control pills and antivirals less effective, and so certainly antivirals are commonly used in many patients with multiple myeloma, and that's something, and certainly pain medicine, so important to understand that. We know that valerian root, hops, passion flower also can affect opioids and make them more sedating. Echinacea can cause a number of things, and we're going to go through that in a little bit more detail. Melatonin can increase sedation, and kava kava can be very hard on the liver, and so we really don't recommend that people use that at all. So the next slide, slide 11, I know this is a little bit busy, but if you just try to look at the color scheme here, this is actually a really nice table that comes out of one of my primary resources in this area and what I try to use with my patients, so it's not just because I said so, but it's based on what we know with the available science. So what this is showing you is how we decide if a supplement is safe, and this is what I use in my practice. And I say, you know, if it's effective and safe, great. If it's possibly effective or we don't really have enough information but it's not harmful, well, you know, I'm not going to really recommend this. I'm going to say, you know what, I need more evidence. And if there's no evidence at all, no scientific studies in human beings to say that there's benefit, and it has any kind of unsafe, or we don't know anything about it, then I'm going to tell you don't take it. So we really try to use this model to regulate how we work together with you in integrating some of these into your lifestyle. So the next slide, size 12, is grapefruit juice. So pour grapefruit juice. It's very good for you, and we all love it, but it is something that completely interacts with the cytochrome P450 pathway that we just talked about in the liver. And so if any of you, again, have ever been on a clinical trial, you hear that they tell you do not drink grapefruit juice because it inhibits this metabolism pathway that is so critical to many, many drugs, whether they're oral or given IV or by injection. So unfortunately, grapefruit juice becomes a problem for many of these drugs, and you should really discuss that with your providers to see if that's something that you can use safely in your diet. The next slide is talking about, we hear a lot about reactive oxygen species, or ROS, and this whole idea of trying to keep abnormal cells from growing, and this whole concept of antioxidants. So antioxidants are thought to be compounds that counteract these free radicals. So these are compounds that are produced in a toxic environment that can cause cell damage. And many of the prevention studies, so when we talk about cancer prevention, many of those studies are looking at reducing these oxygen-free radicals and thus, therefore, reducing damage to cells. What's very important is to understand that chemoprevention trials, so when you're looking at preventing cancer, cannot be transferred immediately to people who already have cancer. It's a completely different environment in the body, and many of those things that are happening on a day-to-day basis within the cells themselves are entirely different. We also know that that chemotherapy drugs work by producing some of these reactive oxygen species or oxygen-free radicals, and many of the compounds that are being talked about are listed here. So alkylating agents, things like Cytoxan, for instance, or Melphalan, which are very commonly used in myeloma, and cytotoxic antibiotics, things like Doxil, are important to keep in mind because these drugs can interfere with their activity. The mechanism of action of these drugs, so these are some of the compounds that are out there being used that look at, and I'm not going to go, these are very clinical terms, but you may hear some of these things having claims where they work as antioxidants. And again, these should be used with great caution when you're receiving active therapy for your myeloma, because they may interfere with the efficacy or the benefit of treatment. And again, you should discuss that with your providers. So we'll go to the next slide. This is slide 15. And this is really looking at a systematic review of evidence from randomized controlled trials. So these are very well done trials. And this is literature from 1966 to 2007, so a very big chunk of time. And of 965 articles, only 33 met the inclusion criteria based on merit. So it's very important when you're looking on the Internet or reading studies to ask very specific questions. Were these done in rats? Were they done in mice? Were they really conducted in human beings? And was there statistical significance? And I know that can be complicated, but it's very important to really look at the source of information that's out there and what the outcome of this was. So this is from the Journal of the National Cancer Institute. And basically the ones that met this merit, many of them were glutathione, melatonin, vitamin A, only one, and then you see there are many that are very few, only one or two papers that really met this merit criteria. So if we go to the next slide, slide 16, so what is the evidence of using antioxidants during chemotherapy? What you find really is that the data are insufficient to provide a clear guide for clinical practice. And if you think back to that slide with all the colors on it, if we don't know enough about safety, then we're going to question it. If it's safe, but maybe there's no data on efficacy, we're going to talk about it. And if there's data on efficacy and safety, then we're going to say, you know what, that's fine, but let's just keep track of that. So if we see changes along the way, we don't automatically blame the chemotherapy. We need to also account for some of these other agents that you may be taking at the same time of your therapy. So understanding that it may interfere with your chemotherapy or supportive therapies or maintenance therapies, and again, open conversations are really going to help alleviate any of the potential negative effects that having this going on at the same time might bring. So the next slide, slide 17, vitamin C. Sounds like a wonderful thing. Ascorbic acid, which has been around a long time. We know that it is an antioxidant. We know that there are many, many studies that have looked at this. There's a lot of work that was done in leukemia and lymphoma cell lines, so lymphoma also being a B lymphocyte, and looking at concurrent administration with some of the very common agents used in those diseases. We know that in mice, vitamin C antagonizes the therapeutic benefit of chemotherapy. We know that there are many other mechanisms that vitamin C mediates. And we know that there was some intracellular activity, this mitochondrial polarization, which is just a big word to say that it gets inside the cell and does something, that was inhibited by vitamin C. So it acts as an antioxidant when taken orally. When it's given in high doses intravenously, which can happen in some of different settings, it acts as a pro-oxidant. So it's actually causing this reactive oxygen species when given in high doses IV. And so we don't ever recommend that as a benefit because it can actually cause tissue damage. So then the next slide, slide 18, is supplements for immune enhancement. So this is just a phase 1 or 2 trial. So, we know clinical trials, phase 1, 2 is sort of investigation, trying to gain information, looking at safety and efficacy. When you get to phase 3, you have something that's a little more proven that you're going to compare to something that's established. So phase 1, 2 trials are early, but this is really looking at what we call polysaccharide extracts. Most of these are from mushrooms, and this particular study was really done in breast cancer patients. And the question was, are there positive immunological effects? So the very small study, 34 patients, so you have to keep that in mind, and they found that the maitake mushrooms did have some effect on the immune system. However, they had mixed effects, so they both stimulated and inhibited the immune system. So it wasn't only one effect, it was both effects. So the conclusion from this trial, albeit a very small study, is that you have to understand that the effects are more complex. And when you look at these claims of immune enhancement, again, thinking back to the criteria for can you make that claim, and you can't really make that claim based on food safety data. You can only make that claim if you're using pharmaceutical standards that are consistent with what is required by the FDA. So you have to be cautious when you read things on the labels that make these claims without having these well-controlled clinical trials to substantiate those claims. If we look at the next slide, slide 19, some of the other things that have been suggested, aloe vera is often considered an immune modulator, an antioxidant, and chemoprotective, but very important to know that it may interact with certain medications, and long-term use can aggravate ulcers and hemorrhoids. So it's not without potential harm or side effects, I guess I would say. Harm is kind of a strong word, so without potential side effects. Astragalus, also something that people commonly will use as an immune enhancer, can potentially cause hypotension. So if you're on therapies or if you're on blood pressure medicine, that can also cause hypotension. This may make that worse, and that doses in excess of 28 grams can cause immunosuppression, so it kind of counteracts the purpose for what people might be taking it for. So more is not better, I guess, is the theme there. There is a lot of data, however. There's something called a Coriolis mushroom, and there actually is some positive data here in terms of being an immunomodulatory agent or immune enhancement agent. However, doses of greater than 3 grams per day can become toxic. So very important to know more is not better, that it has to be used within parameters that are established based on the current science. And I would just refer you, this is from a very well-written paper that is in the Journal of the Advanced Practitioner in Oncology that has a very extensive review of complementary and alternative therapies. Some other things that are commonly used, ginger, again, can be an anti-inflammatory. Many people use it for nausea and vomiting, and there's been a lot of good data there. That's not really our focus tonight, but you can see that if you use too much of it, it can actually cause GI upset, and it may also alter clotting. So if you're on a blood thinner, you're on aspirin a day because you're on one of the IMiDs, you're on Coumadin, it may affect the levels of those drugs that may have adverse effects for you. It can also interact with diabetic medications and calcium channel blockers that you might be taking for hypertension or cardiovascular disease. Mistletoe is something that many people think is magic for the liver. What we know is that it can cause GI upset. It can actually be toxic to the liver in causing hepatitis, and there are reports of seizures, coma, and death. So I never recommend mistletoe for my patients personally based on some of this. When taken by mouth, it can be very, very toxic. As an injection, it can be associated with flu-like symptoms, injection site reactions, and hypersensitivity reactions, some of those being serious. We know there's a lot of data in turmeric. So turmeric is considered to be an antithrombotic, a hepatoprotective, antioxidant, anti-inflammatory drug. There's a lot of data out of India and Chinese medicine, and turmeric is really a pretty safe drug. But prolonged use, so it's really not intended to be taken forever. Most people are using it in small or short sequences because prolonged use can have a lot of GI effects, and it's contraindicated in people with gastric ulcers and, again, may affect anticoagulation therapy, something very important for myeloma patients. The next slide, slide 21, talks about green tea. So we went through a time where everything had green tea in it because we thought, well, this is the perfect antioxidants, these polyphenols. It is the most widely used herbal product. We found it in every juice and prepared drink, and it was thought to be a wonderful thing. And most of that is this EGCG polyphenol compound, but this also can affect the cytochrome P450 pathway, or the liver pathway, if you will. It can specifically inhibit the activity of proteasome inhibitor bortezomib, so there are well-published studies on this. We don't have similar data available with the newer proteasome inhibitors, but most people will tell you we don't recommend concurrent use. So normal intake of brewed green tea can be safe, 1 to 4 cups a day. However, large quantities of concentrates, so green tea supplements, are not recommended. Higher doses can have adverse effects, specifically having vomiting, diarrhea, confusion, and insomnia. Potential drug-drug interactions. We talked a little bit about the proteasome inhibitors, but we can also see the anticoagulant or antiplatelet effects that are listed here for you. They can enhance other caffeine-containing compounds, so you have to be very careful about that, which can really affect your heart. They can decrease the activity of folic acid, so if you're taking folic acid for a variety of reasons, either for anemia or mucosal integrity, that can affect those adversely. And you want to be very careful about some of the other drugs that you're taking at the same time. So the next slide, I want to talk a little bit about vitamin D, because this is something that has gained a lot of discussion over the recent years. Vitamin D is very important for bone health and muscle health. In non-skeletal disease, we know that it plays a major role in immune function. We know that there are many studies that have been done that vitamin D deficiency may predispose you to the development of certain malignancies, particularly lymphomas. And we know that it can contribute to cardiovascular disease. And so vitamin D deficiency is something that's very important to understand, and particularly in the myeloma population, it's something that we try to monitor carefully because we're very tuned in to bone health. So if we go to the next slide, slide 24, how do you get enough? Well, if you're lucky enough to live in Tucson, where I am today, the high here was 80. We had a very nice, bright sky. We don't worry too much about vitamin D in our setting because we have sun exposure over the course of the year. We worry more about skin cancer, unfortunately. But if you're in that belt in the northern regions where you don't have sun year-round, then you might be predisposed to vitamin D deficiency. Certainly there are other people that are at risk, but we want to encourage people to get their vitamin D level tested, and that's something with the Nurse Leadership Board in our recommendations for health maintenance. We do really recommend that you have this done on a regular basis. And for those people who are deficient, there are very specific guidelines for replacement of vitamin D to overcome those deficiencies. The next slide, slide 25, goes through some of the common food sources for vitamin D, and I'm not going to go through each of these. Unfortunately, cod liver oil is right there at the top. My grandmother used to give that to us periodically, and I can still taste it right now when I talk about it. I'm sure some of you can as well. We know salmon is a really good source of vitamin D. Being outside just for a short period of time each day, maintaining the healthy skin, getting the omega fatty acids, and actually I think these are good recommendations. So when we look at the dosing recommendations for the deficiency, again, you're going to want to talk about this with your healthcare provider. This is slide 26. There are very specific guidelines for replacement based on your vitamin D level. So I'm not going to go through this in detail. These are just some of the guidelines that are out there, but you each may have different recommendations based on your specific testing level. Slide 27 then, interaction with other medications. So corticosteroids may inhibit vitamin D metabolism. Weight loss drugs may inhibit vitamin D metabolism. So if you're taking supplements, they may not work as well in this situation. And if you're on an epileptic drug, phenobarbital or Dilantin, they may inhibit vitamin D absorption. The next slide, just simply bone-friendly lifestyle. Stopping smoking is probably the best thing you can ever do for yourself for all kinds of reasons. Avoiding excess alcohol, being sure that you have adequate calcium. It's very important for myeloma patients to understand the balance of calcium. If you have excess calcium because of your disease, or you're on drugs like Iridia or Zometa, you're going to need to have a conversation with your providers to make sure that you're at a safe dose for you. Exercise is always encouraged. You need to be sure that you are taking into consideration any bone issues you may have as an individual. The next thing I want to talk about for a moment, and then hopefully we'll be close to the end here and move on to questions, is the management of neurotoxicity. So we know that neurotoxicity or neuropathy can be a common problem in patients with myeloma, either by virtue of the disease itself or some of the therapies that we use to treat the disease. So we always focus on where do we start, how is it changing over time. We rely a lot on you as a patient or a caregiver to help us understand how things are changing for you over time. And I particularly like to focus on what I call activities of enjoyment or employment. So things you do every day for enjoyment or employment that mean something to you. And if this neurotoxicity or this neuropathy, numbness and tingling, interferes with those activities, that's an important thing to consider. We're going to try to talk to you also about things that might interfere with your treatment. So we talked about the green tea and the proteasome inhibitors. There are some things that we know that might help this: emollient creams, physical therapy, stress reduction. Acupuncture actually has very good data for treating neuropathic pain. So it isn't so much that numbness and tingling, but it's the pain that may come as associated with that. And then if you look at the next slide, slide 30, you'll see that there are a number of things that may be recommended, but there are some safety guidelines associated with this in terms of trying to reduce the incidence or treat pain associated with peripheral neuropathy. What I want to mention specifically here is B6, vitamin B6. So vitamin B6 should not exceed 100 milligrams a day. In excess of 100 milligrams a day, it actually becomes neurotoxic. So it can actually completely contradict what you're trying to overcome. If we go to the next slide, slide 31, we hear a lot about glutamine. So there's been a lot of data on glutamine. It's mostly used for mucositis. Some people have tried to use it to prevent neurotoxic or neuropathy. It's safe in doses up to 570 milligrams per kilograms per day. Most of this data is based on bone marrow transplant patients trying to reduce the negative effects that we often see with the high doses of chemotherapy and mucositis. And slide 32 just goes into that in more detail, and I'm going to skip over that and go to slide 33 so we have time for questions. When we look at energy therapies, these are things like therapeutic touch, healing touch, and Reiki. Some of these have demonstrated some efficacy for pain and anxiety, particularly anxiety relief. There are no known side effects or potential interactions, so really they're very safe, and they really don't require a lot of expenditure on the part of the patient. So this is something very good, and there are several 100,000 practitioners that have been trained in these modalities over time. So it's something that can be considered, and you might ask about the availability of these in the clinical setting that you might be. The next slide, slide 34, goes through some of those distinctions of individual, what is therapeutic touch, what is healing touch, and what is Reiki, and what are the requirements for a person who is trained in these modalities. And again, I won't go into that detail right now, so we have some time for questions, but this is here for you as a resource to refer back to. And again, the reference is there on the bottom of the page if you want to go to the original publication. The next slide goes again into more detail about these in terms of safety and efficacy, and I think the important line here is the safety line, which says there is no harm. So to me, that is a very positive thing. The next slide, slide 36, is really a number of what I consider to be verifiable resources that are available to you online. So there's a Center of Complementary and Alternative Medicines. There is what I think is a wonderful resource, the Natural Medicines Comprehensive Database. This is something that does cost money, but it is updated regularly and vetted regularly, and they really use that algorithm that I mentioned earlier, looking at safety and efficacy and whether or not you might recommend a particular compound or type of treatment or not. The National Council Against Health Fraud, so there are people that may be making claims, and they are also a place you can go to say, is there anything really negative that's been found about a particular recommendation. So the last slide in conclusion, use of CAM is common in cancer patients. We heard that. I think my practice is always moderation is the key. That's true of anything, diet, activity, really being, having moderation is the key. More is not better, so mega doses of therapies given by oral or alternative routes are not really recommended. They haven't been adequately studied, and it's important to keep that in mind. We cannot extrapolate what we learned in prevention trials to the use of these during active therapy, and we've had a very active prevention program here at the University of Arizona, and we found that many of the things, we went through the phase of beta-carotenes. People were taking, so much carrot juice that their palms were orange, their eyes were orange, and we now know that that really wasn't proven. We know that there is little known about CAM use with novel agents, and we know that energy therapies and mind-body therapies produce no harm and may be helpful for some patients. We always encourage diet and nutrition and exercise tailored to the individual patient, so it's important to know if there are any limitations for you based on your medical history. That we now have many of these supportive or palliative care trials that are encouraged, and we study this often in conjunction with active therapies. So we need to learn more. We encourage participation in these trials so that we can have more data and be able to say things with a little more certainty. And then once again, just having open conversation about all medication, supplements, and other therapies with your healthcare provider. And with that, I will stop and allow questions.
Thanks, Sandy. That was really great. So let's now open up the lines for questions. And as a reminder, if you have a question that you would like to ask Sandra, please remember to keep it general in nature, but specific to myeloma, so it will benefit all the listeners on this teleconference. Karen, do we have anyone in the queue for questions for Sandy?
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. You have a question from the line of Bill Brewster.
Yes, Karen, turmeric, I guess, is the same as curcumin. The Mayo Clinic was doing some studies of using curcumin as a supplement. What are your thoughts on curcumin?
So this is Sandy, actually, and there have been a lot of studies on, and curcumin is turmeric, so you're correct. That is the same thing. And there have been a lot of studies on turmeric, curcumin, in looking at the treatment of anemias, in looking at immune health, and most of them have been found to be safe. Efficacy varies based on dosing, and so again, if you refer back to the slides, there are some recommendations not to exceed certain doses. And again, I would refer you to those resources that I mentioned on the next to the last slide for some of the specific dosing guidelines.
Okay, thank you.
Yes.
You have a question from the line of Jack ILO.
That's a good pronunciation. Thank you. I enjoyed your presentation very much, Sandy.
Thank you.
I had one quick question, and that was on slide 18. You talked about a mushroom clinical phase 1-2 trial,
yes.
And I wondered, did it ever progress to a phase 3? But my broader question has to do with slides where you talked about green tea being safe as long as you're not taking it while you're getting Velcade, or peripheral neuropathy, you talked about these things being safe. But have there been results to show effectiveness? And if there haven't been, I thought I kind of heard you recommend using the product, but that would go against your red, yellow, green slide. so I'm a little confused.
So the slides on. So first of all, green tea. We don't recommend that you use it during your therapy. In the general population, it's safe to take it in moderation.
But is it effective?
In tea. Well, there isn't a lot of good data in terms of immune enhancement. It's not well proven, but it shouldn't cause great harm if not taken in excess. I think that what we see clinically is that suddenly then they put it in a pill in a super form, so it's a higher dose extract. So the moral of the story is nutrients are really intended to be taken in foods, not in a pill form. And that, if you just apply that general concept, that nutrients are really intended to be taken in foods, not in pill form, that goes a long way in trying to avoid excess dosing. In the neuropathy slide, what they're saying is that there's some data for those specific compounds in treating neuropathic pain. Almost none of them reverse the numbness and tingling, and most of them have had no proven benefit in preventing the onset of numbness and tingling. So it's unfortunately an area where we really haven't learned enough. There are many people trying to study this, and hopefully we'll come up with a good strategy to reduce the incidence and prevent people from having neuropathic pain.
So they do kind of fall in your yellow box?
They're probably more yellow, not red.
Okay.
Yeah.
Thank you.
Mm-hmm.
You have a question from the line of Gail Pollard.
Yes. I'm encouraged a lot to take CoQ10. Could you give me the purpose of this supplement and if you know any positive or negative effects?
Sure. So CoQ10 is considered an antioxidant. It is not often thought to be as strong an antioxidant as vitamins A, E, or C, but it is still considered an antioxidant. So in our practice, we recommend that people not take it concurrently with their therapy. There has not been a lot of data published to date on a great deal of harm in standard dosing. So, again, if you're on therapy, we recommend that you not take it concurrently because it's in that group of antioxidants. If you're not on therapy, we would say simply, you need to refer to the common dosing regimen and try to adhere to that.
Okay, thank you.
Uh-huh.
You have a question from the line of Candy D'Addario.
Yes, I have a question about on the vitamin C. Did I understand you to say that it's safe to have vitamin C in foods so that then it would be okay to eat oranges?
Yes. So, when you take so most foods, you would have to eat bushels and bushels or buckets and buckets of these foods to have excess amounts of vitamins. So if you have a balanced diet, which is what we recommend, and it includes things that have vitamin A, vitamin E, vitamin C, any of those things, that's fine. Oh. But what we're saying, grapefruits are another story, and we talked about that. But what I'm saying is that nutrients from foods are very different, and they're processed very different by the body than nutrients that are taken in pill form, particularly those that are megadose vitamins. So eating oranges is okay.
Okay, and a quick related question. If green tea can have harmful effects, what about black tea?
So interestingly, there's a lot of data on regulation of teas. And so teas are not highly regulated. They're a food substance. So some of the other teas can have similar effects. The green tea seems to have more of this ECG compound in it, and that is specifically what was studied in these reports or these papers that showed interference with proteasome inhibitors. So having a lot of tea of any kind during therapy is probably not recommended. I think the focus became that there was so much green tea put in artificially in compound form to many, many different drinks that were on the market that it became more of a concern. You don't see, protein drinks with black tea added.
Okay. Okay, well, thank you very much.
Uh-huh.
You have a question from the line of Harold Hammer.
Oh, hi. Thank you for your presentation. This is Dr. Harold Hammer in New York City. And I wanted to know about yoga and why it's recommended. When I was very ill, my doctor suggested I try yoga. And so I went to 2 different kinds at a local commercial but very, very good gyms and watched. And I kind of thought I would recommend both for anyone who was interested in the Spanish Inquisition and torture. The people there were having a hard time. They weren't in bad shape, but they were ordinary New Yorkers, and people were falling, and I was really worried about my bones.
Yes.
And so I just never, I don't think yoga is good for you.
So there are many different kinds of yoga. There are the true yoga aficionados who do the pretzel moves, and that's not something we recommend for myeloma, so I'm glad you brought this question to light. I think that the general principles of yoga are to strengthen muscles, increase flexibility, and to promote relaxation, and so just really bringing people the stress levels down. But there are ways to do gentle yoga. There are programs specifically for people at risk for fractures. So that's so I'm glad you brought this question to light. And I think when we talked about bone health, we always say whatever the exercise program is, whether it's yoga or other kinds of things, you always want to talk to your providers and say what is safe for me. And yoga would fall into that same category. But there are there are yoga programs that are focused more on stretching and just muscle toning and relaxation that can be, perfectly fine for someone with myeloma. But I'm with you. The extreme yoga to me might be a form of torture.
Well, I just want to add, this summer I kind of went back to my second childhood, and Battery Park Fields, which has a synthetic turf, I began, when the kids weren't around, kicking my light soccer ball around, and I couldn't believe it. I kept worrying so much about my back, and I just don't know of anything that's made me feel more flexible and strengthened in my lower body.
Good. That's good. So just being safe, understanding your limitations, never hurts to have a physical therapy evaluation before you begin something. Or see an orthopedist, or certainly just talking with the oncology team to say, what are my vulnerable spots? What should I avoid? And then physical therapists can actually give you just strength training exercises that are very focused and also avoiding areas of vulnerability.
You have a question from the line of Joyce Schultz.
Yes. Hi. This was an excellent presentation. I really appreciated listening to this. A couple of questions. One, this may be silly, but is there any difference or harm in the gummy version of these these newly created vitamins and supplements? Is there any benefit or problems that might arise with those? And also, where could we participate in some of the clinical trials that would be, or some of the studies that would be studying some of these effects that supplements and vitamins and things have?
So I would refer you, number one, I don't know about the gummies. I don't know that they're regulated because they come under that other umbrella, so I'm sorry to say I don't know the answer to that question.
Okay.
I would have to investigate that further. As far as available trials, so the supportive care trials that are conducted, there is the Multinational Association of Supportive Care in Cancer, something called MASC, and they have taken on a great deal of the studies that are looking at these kinds of things. So you can go to, I don't know if it's masc.org, but it's MASCC, and they are a group of professionals really studying intensely these supportive care strategies. So you might check there to see available clinical trials. The National Cancer Institute, clinicaltrials.gov will also profile anything that's registered for them, particularly if it's done in sequence with other therapeutic trials.
Thank you very much.
Mm-hmm.
You have a question from the line of Arnold Kupek.
Hello, and thank you for your presentation. I'm reading slide number 12, grapefruit together with cytochrome P450 3A4 substrates. Apparently sounds like not a good idea. I'm wanting a further definition of cytochrome P450 3A4 substrates, whether or not these are the myeloma medications that I'm taking.
No, so many drugs are metabolized via the cytochrome P450 pathway, and the list is extensive. It's longer than the list for Coumadin interactions. It's longer than the list for things that affect the heart rhythm. And so you can go, what I would do, and every clinical trial includes extensive lists of things that may inhibit or enhance this pathway, so therefore either making things less active or more active, and so if you have more than one drug that affects cytochrome P450, so if your chemotherapy agent or your myeloma agent is metabolized by that pathway, the key is not to take other things at the same time that may inhibit or enhance that pathway, because it will change the way that drug might work, and it may either be ineffective or become more toxic. So with that, there's no way to really cover every potential combination.
So I have to get information relative to the drug and the pathway.
Right. So this is where really just having a conversation with your provider to say, here are the other things I'm taking. Is there any potential interaction? And many times the best person to help you with this is a clinical pharmacist, and or there are websites that look at, I always go to www.drugs.com, and they have a interaction tracker that can help you understand some of those potential interactions.
I see. Yeah, we've been eating grapefruit in the wintertime for many years, and I've also had myeloma for 11 years too. Thank you.
Okay.
Okay, so thanks, Sandy, for taking the time this evening to help us better understand the importance of complementary and alternative medicine as it relates to myeloma. It's obviously an important topic, a good topic for us to continue to have conversations with our doctors, make sure that they know anything that we're taking in addition to our myeloma treatment so that there are no contra-interactions happening with that. So, again, thank you, Sandy, and we'll be done with our questions for this evening, but I want to let everybody know that if your question was not answered tonight, Dr. Durie will be taking questions on the subject, and you can